So my topic will be a polytrauma, particularly related to the something like neurology, some related to neurology, particularly polytrauma. See, trauma is a totally a different domain because are you able to see my slides?
Yes, sir.
Okay. So this topic is basically very important because trauma itself is a different domain, and the guidelines and everything is totally different for a trauma case compared to your other medical case or surgical case. So what is very much important is that the candidate should be thoroughly well versed with the recent trauma manual, ATLS guidelines, and everything which is being recently published. So we'll start with a very simple case. So this is basically a case, 46-year-old gentleman, alleged history of RTA four-wheeler versus two-wheeler collision. So patient is drowsy, restless, barely following any commands. He is tachycardic, regular pulse rate, and peripheries are cold. Blood pressure is on the lower side, and there is a trauma to the right lower limb with massive swelling and bruising. Okay, there are severe abrasions, injury in the abdominal wall on the left and right side of the back, trauma to the right lower limb with massive swelling and bruising, and patient GCS is 11 by 15. Of course, the patient came to the emergency department. 1500 ml of fluid was given, and it showed partial recovery, and further reading shows the blood pressure has slightly improved to the range of 88 by 45, but which is also still not very adequate. So when such type of cases are being given to you, I think almost most of you have mentioned all the questions correctly. I think and answered the question correctly. So just evaluate the scenario. What is the mode of injury and what kind of injury the patient has sustained, particularly if this is a head-on-head collision or there is a fall. So you always suspect there is a cervical spine injury also. So and also when the patient is having a direct blunt trauma or penetrating trauma to the chest or abdomen, you have to be very, very careful because sometimes these injuries may be missed on your examination, and ultimately you just go on you're treating the patient for the head injury, but actually this hemorrhagic shock which is developed because of the occult injury is very, very vital. That is the reason they says that always screen your all the important areas of the patient whenever such patients are coming to you. So particularly if you classify this case, this is a case of polytrauma with shock. Polytrauma means more than two organs being injured. So the patient may have sustained an head injury here. Also, the patient may have sustained to the right lower limb injury. The very important point here is that whenever the patient is having a trauma to the right lower limb, always suspect, and the patient is hypotensive, always rule out your pelvic bone fracture, particularly the open pelvic bone fracture, because it has been found that in a pelvic injury, the blood loss amounts to 2 to 3 liter almost, 3 to 4 liter almost. And when there is a injury to the fracture femur, the blood loss amounts to in the range of 1 to 2 liter. That is the reason these patients, if there is a suspicion of pelvic injury, you have to immediately take the patient to the OT, particularly the open book fracture, and you have to also sometimes take them to the cath lab after the resuscitation. Okay, so this is the scenario where you find that a patient is having multiple injury with shock. Okay, so these are the different questions. So what are the guiding principles? Initial management, what are the investigations, and what are the primary survey you do, what are the secondary survey you do, and what are your goals. So the examiner wants to know whether you know the ATLS guidelines or no. So there are various guidelines, particularly the most important guidelines what we follow is the ATLS guidelines. So which is actually the recent 10th version of the ATLS guidelines. So I request everybody to just go and read what are the changes from the 9th edition to the 10th edition. Okay, what are the recent concept actually they have incorporated in the 10th edition of the ATLS survey. So the ATLS survey itself says that whether it is a 9th edition or 10th edition, it is a like airway with cervical spine control, breathing with ventilation, circulation with hemorrhage control, disability assessment in the terms of neurological and also in terms of what are the injury. Okay. Fourth, your something called as the environmental. Environmental means your exposure and environmental control. So these are the ABCDE, which is different from the normal CAB from your cardiac arrest. Correct? There are also various other guidelines. There are WHO guidelines. There are injury severity scoring systems. There are World Federation of Neurological Society guidelines. There are also something called as the other the your trauma scoring system. So you just go and read how the scoring systems, your prognosis depends on your scoring system. So patient who had a polytrauma with injury severity score very high, particularly in such patients, you anticipate the patient may go into deteriorate rapidly. Unless until the examiner asks you regarding the injury severity scoring system, don't utter any word, but you have to know what are the different injury scores. Okay. So abbreviated trauma score, injury severity score, WHO score, all these things are very, very important. So they may give a scenario and they may ask you calculate the injury severity score and what how your prognosis different when the injury severity score is more than 35 or more than 30. So that you should able to answer it. Okay. So this is one thing. And second thing is the initial guiding principles you already told. Never ever forget to look for the or suspect cervical spine injury in a trauma patient. This is very, very vital. This is very, very important. Everybody should answer about the cervical spine injury. So unless until it is proven otherwise, every trauma patient, particularly with a head injury, you should always suspect the cervical spine injury. That is the reason. So it is called the airway with cervical spine control. Now, many of you didn't able to answer how to clear the cervical spine. Okay. So can somebody here answer what are the different criteria to clear the cervical spine, particularly what are the clinical criteria and how do you radiologically clear the cervical spine in a trauma patient, particularly in a polytrauma patient?
The two criteria available, Nexus and Canadian C-spine criteria.
Okay.
Uh,
So can you
uh,
describe what is Nexus criteria?
Nexus criteria contains spinal tenderness, neurological deficit, age more than 60 years, distracting injury,
Perfect.
and
Last one. One more is left.
paresthesia.
Paresthesia. Correct. So this is a very simple. Nexus is very simple. These are all screening criteria, particularly for a simple trauma patient who has sustained head injury. Nexus criteria. They have made it very, very simple. Only 5 points are there. But when you go to the Canadian C-spine rule, basically, this is little bit more.
Canadian C-spine.
Can you just make your microphone the mute? Yeah, so Canadian C-spine is little bit more complex, more methodical, and your something called as the flow chart based. So can you somebody tell me about the Canadian C-spine rule? So it is almost yeah. Can somebody know what is? Tell me what is cervical your Canadian cervical C-spine rule?
Dangerous mode of injury, expulsion from the vehicle, fall from more than 3 meters or 3 feet or
Yes,
1 meter,
yes.
uh, uh, age more than
65.
65 years,
Yes. Any other thing?
Spine
head-on collision.
tenderness, movement. Uh,
Yeah. So in Canadian cervical spine, they have clearly mentioned regarding the one is the something called as the type of injury, the mode of injury, the age, and of course they also incorporate some of the clinical examination. If they don't suspect that the patient is having a cervical spine injury, you can also allow to little bit move the your cervical spine in or absence of all these criteria. So there are weak no's like no tenderness, no paresthesia, no motor deficit, no head injury, and no such mode of injury where the patient is being thrown out of the vehicle. In those cases, you can allow to move. And of course, if you suspect there is a slight suspicion, you have to ideally do the radiological investigation in all such patients. So the aim of both these criteria is that they actually want you not to go for all the patients cervical spine screening rather than only in selected patients. You have to focus on the cervical spine screening, not in all the patients. That is the most important point. Okay. So suppose somebody has a suspicion of high index of suspicion. So what are the investigations they recommend? So like what investigation you do?
CT scan of the spine.
Yeah. And does X-ray of the cervical spine is recommended?
I mean, it has a false negative rate.
Yes, correct. So that if you want to actually do a X-ray neck, ideally you have to take three X-rays, two X-rays, okay, three X-rays. I mean to say, if possible, okay. So that is the reason. So to X-rays, they don't have given a topmost priority, but rather than you have to just go for the CT scan of the neck. If you so that is the reason. Whenever you do a CT brain, do not forget to do a CT cervical spine. Particularly screening of the all the spine is very vital. The other very important point is that you have to always mention the initial GCS and initial motor deficit at the time of presentation. Very important. If the patient comes to you with a deficit of the lower limb, but upper limbs are moving, particularly, this is the initial presentation. Particularly those patients, they have definitely some kind of spinal injuries and spinal fractures or cervical spine fracture. Be very careful. In those cases, the guideline says that you can subject the patient for the MRI if your CT doesn't show a major fracture or something. That is why the initial motor assessment at the time of presentation in a polytrauma patient is very important. So you have to examine, even if the patient is on sedation, give a painful stimulus, see for the movement. If the patient is not on sedation, if the patient is, suppose for example, on ventilator, sometimes he may be conscious, tell them to move your limb and assess the motor power of all the limbs, upper limb and the lower limb. Okay, so that you do not miss out any kind of fracture. Okay, that is the thing. Now this is called the primary survey. So primary survey means it is not only primary survey. The 10th guidelines has clear cut said that it is primary survey along with the resuscitation. You have to do the resuscitation simultaneously while assessing for the primary survey. Don't just focus on the primary survey. Your resuscitations are very important. That is the reason the goals of resuscitation is very clear. Go for something called as A, B, C, D, E approach and give fluid, take IV lines, give enough crystalloid, almost ringer lactate or normal saline in the range of 1 liter. Then assess for the vital parameter, take wide bore lines, central lines are not at all required. While you do a puncture of the peripheral lines, you send for different blood investigation, particularly send for the blood glucose, particularly send for the blood grouping and cross matching in a trauma patient. This is very important, and particularly sent for the coagulation parameters. Okay, many of the patients with polytrauma, they may be coagulopathic because of the, a lot of multiple factors like your release of your trauma is itself is a condition of your coagulopathy. That is called trauma-induced coagulopathy. Okay, and of course the routine CBC and other urea, creatinine, and whatever the blood test Do not forget to do the ECG. That is why the primary investigations, because many of them have sometimes injury to the cardiac or myocardium, and there can be a cardiac contusion or cardiac trauma may be there, or the patient had a pre-existing cardiac pathology which may get precipitated during the stress. Okay, this is the two things. So what are the investigation you said? These are the basic. And if you are ICU physician or ER physician, always tell the examiner that you have to do a 2D echo and the USG fast or EU fast, something which is called the extended fast protocol for the trauma. So ultrasound and 2D, that is the thing. So what constitutes the secondary survey? So basically, what are the different types of surveys? One is called primary survey with resuscitation, secondary survey with resuscitation, tertiary survey with resuscitation. So what is secondary survey, what are tertiary survey, and how do you proceed for secondary survey? What are the means your patient, this patient? Can somebody tell? Or just so secondary survey is basically like you have to always after the patient gets stabilized, you have to do the secondary survey. Secondary survey is basically nothing from the head to toe examination. Okay, very clear. And back examination, front examination. But the patient has to be stabilized. Any time during the secondary survey, you feel that the patient is unstable, you have to again go back to your resuscitation again. Okay. So secondary survey is head to toe, and here you have to examine every missed injuries which are not life threatening. Okay, and that is to after the patient being stabilized. This is called the secondary survey, and here you have to take the history. The history is, and primary survey is always followed by some adjuncts to the primary survey, like the simple X-ray of the chest, X-ray of the pelvis. Okay, Whereas secondary survey always preceded by a history and adjuncts to the secondary survey, like whatever you suspect, which is not life-threatening injury, which can create problem in the future. If you want to rule out like CT scan, then you have to do in the secondary survey. But this history is very, very important in the secondary survey. There is something called as the ample history. So A for allergy, M for medications, L for last meal, events leading to these episodes. These are called the secondary survey. Okay. Now, what is damage control resuscitation? This new concept in which is described in ATLS, and what are the damage control surgery? So damage control resuscitation. So what do you do in damage control resuscitation? What are like the things normally you go, like what are your goals of damage control resuscitation? How it is being practiced?
Not a definitive
Damage.
procedure, an external fixator for a long bone injury example, or a
So
packing
you
of
are you are talking
Amos.
about the damage control surgery. What are the damage control resuscitation?
To
So
keep,
there are three
to
components
keep-
of damage control. Yeah.
Damage
To
control
keep-
surgery, one of it.
Sorry.
to
Damage
keep,
control surgery, one of it is damage control resuscitation.
I didn't get you. Like what you meant to say in damage control resuscitation? What do you do? Step
to
one,
keep
step two, step.
systolic BP around 90 mm of mercury.
That is called
Permissive
hypotensive
hypotensive.
resuscitation.
yes. Permissive unless until the patient had something you don't do
Spinal and
permissive.
cranial
TBI, traumatic
TBI,
brain injury.
injury.
Yes. Then those cases you have to keep the BP on the higher side. Otherwise, you have to keep a BP on the around systolic BP around 9. That is called permissive hypertension. That is one. Second.
Damage control surgery.
No. Second is your fluid resuscitation and preventing hypothermia, coagulation, and acidosis. Hypothermia,
Oh.
acidosis, and your coagulation, your dysfunction. So that is the reason you have to.
Homeostasis.
Yes. So the previous 9th edition of ATLS has recommended that you can give fluid till the patient responds to fluid. But now the concept is changing from the limited fluid to more and more blood product. If you find the patient is in shock and the patient requires resuscitation, you can immediately ask for the blood rather than giving too much of crystalloid. This is one of the change from the previous ATLS edition. So they don't recommend too much of fluid. Why? What is the reason?
Coagulopathy.
Yeah,
Increased bleeding. And
Yes, to prevent
DIC.
dilutional coagulopathy. Yeah. So your 1 liter of normal saline or ringer lactate, both you can use, both are enough. Okay. If you give too much of fluid, it can cause dilutional coagulopathy and there may be indirect bleeding. Okay. That is the reason you have to ask for the blood products. And if you suspect there is a massive transfusion, you can ask the blood product in the ratio of RBC plasma to platelet.
1 to 1 to 1.
1:1.
Correct.
1 to 1 to 1.
Correct. So this is, and also you have to simultaneously warm your patient. Okay. Warm your patient and you have to prevent hypothermia and acidosis. These are the two, this is the vicious cycle, which is very important. You have to break the vicious cycle. This is the three steps approach for damage control resuscitation.
So
Now
second part of this strategy, in general, in brief, what we can say in exam. First one, this permissive hypotensive. Then second one we'll say like homeostasis or
homeostasis.
Homeostasis.
Yes, homeostasis. What is damage control surgery? What is damage control surgery?
Just to control hemorrhage initially to manage this shock, and later on preventive surgery maybe later. But this only resuscitative surgery to control hemorrhage.
Correct. So here there are two things. One is control of hemorrhage. If there is a life-threatening injury, control of hemorrhage is one thing. Second is to prevent the contamination of the abdominal wound or abdominal viscous. Like for example, there may be perforation, there may be something, and because of that, there may be chance of contamination to the all abdominal cavity. So the purpose of the damage control surgery is, one is to stop bleeding and second is to prevent the contamination. Like if you find there is some perforation viscous, you have to just do a primary suturing rather than doing a definitive repair, or just clip and clamp or do a stapler and prevent the bacteria from get spilled from the intestine to the abdominal cavity. That is called the prevention of infection. And once then ICU care. ICU care means in the damage control surgery, the second part is the ICU care, and then you bring the patient to the ICU, stabilize the patient with all the antibiotics, blood production, your fluids, and then again take the patient for the definitive surgery. This is called the damage control surgery. Okay. So this is what is your differential diagnosis for hemodynamic instability and shock in your patient? Your patient is having a blood pressure of 80, and now you find that this patient is shocked. So, of course, so what are the causes? The examiner wants to know tell you that what are the different causes of shock you know in a trauma patient. So, first and foremost, do not
Hemorrhagic
forget hemorrhagic tail for hemorrhagic shock. So shock in any trauma patient is a hemorrhagic shock unless until proven otherwise. Okay, this is very important point. Of course, there may be multiple causes of shock. The shock in a trauma patient may be multifactorial. It can be like cardiogenic shock. It can be like
septic shock.
septic shock. It can be like obstructive shock. It can be like distributive shock. But the most common cause is hemorrhagic shock. So what are the different types of if you evaluate your patient, what grade of hemorrhagic shock you anticipate in this patient? So the blood pressure, which is 80, has increased to 88. The heart rate, which is 150, has decreased to 120. So what are the different grading of the hemorrhagic shock? And what grade your patient belong? Do you think that your patient will require blood and blood products in this grade? So can somebody tells me about the different grading of the hemorrhagic shock, grade 1, grade 2, grade 3, grade 4?
Grade 1 means less than 50% of the body volume loss.
Yeah.
Grade 2, 50 to 30. Grade 3, 30 to 40, and more than 40% grade 4.
Yeah. So this is you told me regarding the blood loss, but if you see for the hemodynamics, particularly, so what grade of shock this patient is having?
3 or 4.
Yeah.
Or 4.
3 or 4, correct. So in 3 or 4, what is the ideal replacement fluid?
Blood products.
Blood and blood.
Acid transfusion.
Okay. Yeah. So grade 1 shock is always your patient will not have any hypotension. This is the most important thing. Okay. So your patient blood pressure may be normal in the grade 1 shock, whereas in patient have decompensation in grade 3 and grade 4 shock. Okay. So how do you proceed? Now you have given the blood and blood product. You have asked for the blood and blood product, but of course, when you told or when you tell your examiner that I will do an ultrasound and 2D echo, so that is the reason this question is being asked. So like what are the different your protocols for the ultrasound assessment in a particular trauma patient? What protocol you are going to follow, and what are your protocols for the 2D echo assessment?
E-fast for the
E-fast.
abdomen
So how do you screen the E-fast? What are the different areas you screen? What is E-fast is extended fast. Okay, so what are the areas you screen? And what?
the epigastric region. In the epigastric region, the pericardial tamponade, possibility of pneumothorax, then right hepatorenal pouch and
Yes, linorenal pouch of Morrison. Okay, your hypogastric area, your pelvis, bladder. Okay, and also you have to look for the splenic lacerations or your splenic area and your liver area. And is there any free fluid in the abdomen? Okay, so these are the areas you need to screen, right? One questions maybe this is just a theoretical question, but this may be asked. What do you mean by the trimodal distribution of depth? So this is very important.
Acidosis and the hypothermia.
So why it is called trimodal? Why it is called trimodal? Why trauma death is called trimodal?
if there is a massive hemorrhage or a life-threatening injury within the first hour, there can be a death. And beyond that, due to the continuous hemodynamic instability, patient may contribute to mortality in the next 24 to 48 hours. And following that, due to secondary infections or
Yeah. So one is called the very early death, second is called the early death, and third is called the delayed death. So delayed death is probably because of the multi-organ failure and sepsis and infection. Very early death is because of the major either vascular injury or because of the airway injury. Okay, this is why this is the trauma case is called the trimodal distribution of death, and there is something known as golden hour. I think everybody knows about golden hour, correct? So the golden hour is the time where actually before the patient deteriorates, you have to start your treatment actually. That is called the golden hour of the trauma patients. Okay, so this is just something called as the first peak and second peak and the third peak. So first peak is from 4 to 6 hours to 24 hours. Second peak is from 24 hours to something called 3 to 5 days. And third peak is more than 7 days or weeks. Okay. So this is just a theoretical aspect. Now this patient Yeah, he complains of severe pain in the left shoulder, thorax. He is still tachypnic, desaturated with 4 liters of oxygen, normal breath sound, but very rarely audible heart sounds. Patient is breathing quite heavily and he needs now the oxygen requirement has gone up. Blood pressure further drops. You have almost given a fluid of 1.5 liter, and there are engorged and distended neck veins. And if you see the ABG is having particularly severe metabolic acidosis along with low hemoglobin and also respiratory compensated, you can say respiratory acidosis. Lactates are on the higher side, 8.5. This is overall the picture. Any guess?
Myocardial tamponade.
Sorry?
Pericardial
Myocardial tamponade. He
tamponade,
has
severe metabolic
myocardial
acidosis, lactic acidosis.
myocardial
Yes.
tamponade. Myocardial tamponade.
Yeah, pericardial tamponade. Okay. So this is a pericardial tamponade, echo of the pericardial tamponade. You can see. So what are the different signs of pericardial tamponade on the echo?
Diastolic collapse,
Diastolic, early
Collapse of the
diastolic,
RV collapse.
RV collapse.
right
RV collapse.
ventricle,
Then
and swinging heart sign.
swinging heart sign. Correct. Any other?
What is this sign?
Swinging heart sign. Suppose the patient has a PA catheter. What hemodynamics parameter you will see on the
Diastolic
PA catheter?
equalization of the pressures from the RA, RV, and PA.
So every pressure occurs, all the chamber become equalized. That is also another sign. And so what is like this is one. So then this also the ECG. Anybody?
This
Electrical ordinance.
Q3. This
Yeah. So
is one
most of
Q3 to 3.
you, yeah, most of you have rightly told about this ECG, the pulsus alternance. Okay, which is very typical of your pericardial tamponade. So now the how do you proceed? And if your patient so has a pericardial tamponade, which is a life-threatening emergency, how do you proceed?
You call cardiothoracic surgeon or cardiology teams to pericardial synthesis.
I think paracarditis in trauma is not
Okay.
is
So
not practical.
correct. So most of you have correctly described this procedure like it's a pericardiocentesis through the sub-Gifford approach. But what one thing you also need to understand that suppose you have a time and these procedures can be done under fluoroscopy guidance, which is sometimes is better if you have time, patient gives you the time, it's better to take the patient under fluoroscopy guidance, or otherwise you can do it on the bedside. If you see that the hemodynamics is rapidly deteriorating, you can do it in the bedside, but the complications rates are very high on a bedside pericardiocentesis. Under fluoroscopy guidance sometimes or echo guidance, sometimes this can be well managed because the complications rates are very high. So like it can cause cardiac perforations, your chamber or cardiac injury to myocardial damage to a lot of arrhythmias. So that is the reason. Okay. So echo guidance, pericardiocentesis, they may ask you about the whole procedures, how to approach, what route, how to proceed, how to monitor the ECG, what other monitoring system you require. Okay. And how do you put what are the technique called Salinger technique, and where you keep sometimes there may be a recurrent pericardial tamponade and you can sometimes keep that guide wire in the pericardium also. Okay. And what are the different anticipated complications starting from mechanical to electrical, okay, to all these things you need to describe in a proper structured manner. Mechanical complications like your cardiac injury, septal wall rupture, RV rupture, pre-wall rupture, to electrical complications in the form of your arrhythmias and other thing. Also, there can be nerve and vascular injury also. Okay. So whenever this patient is like tachypneic so bad, you have to ideally intubate them. You have to ventilate them, make them stable. If your time permits, use drugs where the blood pressure doesn't crash, particularly your etomidat or ketamine, and intubate them, and then on emergency basis do a pericardial synthesis. Now suppose this patient, I'll show you the different ultrasound e-fast image of the same patient. So here you can see the upper one is a spleen image of the liver and the lower one is the image of the lungs actually. Okay, so there are different quadrants. So you can find this is something called as the normal lung ultrasound. So A, B, and C and D, and almost all of you have correctly mentioned it. A is having this A lines. Okay, A lines are which are normal. These are the B lines. This is also a B lines, but here the B lines are more dense. Here the B lines are 3 to 5, but not that much dense. So dense B lines are suggestive of something called as ARDS or severe cardiogenic pulmonary edema, or something intrapleural hemorrhage or something interstitial hemorrhage. Or the 3 to 5 B lines are sometimes normal. More than 5 B lines are you may find in interstitial edema. Okay, and this is something, the last image is something your subpulmonary consolidation, lung contusion. Okay, particularly in the lung ultrasound. Sometimes this patient may have a life-threatening something called as pneumothorax. So there is a recommendation for emergency department thoracotomy. So whenever you address a trauma patient, always address the life-threatening injury the first. Somebody had answered actually emergency thoracotomy yesterday, but actually when I show him this 2D echo image, actually it is a pericardio. You can see it's a pericardial tamponade. So whenever such things are there, always address the life-threatening injury first. Do not jump into the other areas. Okay, but there is of course a guidelines for the emergency department thoracostomy. So everybody should know actually what are the indications for ED department thoracostomy. Can somebody tell me? So when do you do a thoracostomy in the emergency department itself in a trauma patient?
Tension.
Tension pneumothorax, I meant to say it is not ICD, intercostal tube drainage, but it is a thoracotomy, proper thoracotomy.
Very large ICD drainage, like more than 1500 in the first hour.
That is one. But that is something like particularly semi-emergency kind of thing. In emergency thoracotomy, I meant to say, in a trauma patient.
If output is more than 1.5 liter at spot or more than 200 ml for hour,
When
per hour
chest
for 4
compression
hours.
is difficult.
Yeah, so the guidelines suggest if there is a cardiac arrest, patient is going into peri-arrest situation with a large ongoing bleed into the lungs, in particularly hemothorax, large hemothorax, where you suspect there is ongoing bleeding. Patient already is in cardiac arrest, so there you can directly do a thoracotomy in the emergency department without taking the patient to the OT. To just to clamp the vessels and save the patient from because if blood get accumulated rapidly in the your pleural space, this may compress your heart and this can cause secondary compression on the heart and low cardiac output state. So to relieve that, you have to do an emergency department thoracotomy. Particularly these thoracotomies are like there are different incisions are being described. You just go and read what are the different incision, like you have to instruct your surgeons, but sometimes they may ask you. So this is one of the indications. Okay. But of course, ICD is for the tension pneumothorax. That I agree. Okay. If you suspect tension pneumothorax, like you have to immediately put an ICD. Okay. Now this patient, what the picture I show you with the splenic injury and the liver injury, I think everybody appreciate there is a contusion, liver contusion and splenic lacerations. Okay. So you just see the free fluid space between the spleen and the diaphragm, and there are intrahepatic your contusions which is being marked. And with the persistent hemodynamic instability, what do you think the next step of action? Sorry, what do you think? What should you do?
Emergency laparotomy.
Emergency laparotomy. Okay. Do you do a CT scan? Do you see after the CT you want to shift, or you just directly shift the patient, or you do it like on the ultrasound basis? What you find you can directly shift the patient. What is the like?
CT scan with IV contrast.
Yes.
CT abdomen pelvis.
Yes. So if you're see there is no stricter guidelines for do a CT in a trauma patient. Remember this. Unless until your patient is stable, you don't have to do a CT scan. Do not rush to do a CT scan at all. You can do if your patient is responding to fluid blood after stabilization, you can do a CT scan with IV contrast. But suppose your patient is not fit for the CT scan, you are in doubt on the ultrasound finding also, you can go for do a exploratory laparotomy. Some cases they have described where the CT and ultrasound is not possible or inconclusive. You still suspect the patient has abdominal distension or the patient need to be taken for the emergency laparotomy. Those cases, what do you do? Now those methods are little obsolete, but sometimes it may be practiced in some centers.
DPA, diagnostic peritoneal lavage.
Diagnostic peritoneal lavage, DPA. Yeah. So how do you do DPL?
Lower forward.
How do you do
Using
DPL?
a
What? Yeah. And how do you
using a
interpret?
stiff needle.
Huh?
Using a stiff needle, you prick 2 centimeters below the umbilicus, and for pregnant patients, 2 centimeters above the umbilicus, and aspirate the fluid.
In
And
fact,
then
pregnancy is a relative contraindication for the DPL. Okay. Relative contraindication, I mean to say, be careful in particularly such patients. Yeah. So then how do you proceed after location?
to get sufficient fluid that can be sent to find out if there are more than 1 lakh RBCs.
How much fluid you give? How much fluid you infuse? Almost a liter. Okay.
1 liter.
Almost a liter. And what do I then again you aspirate the fluid? What do you see in the fluid?
Just a
Can you check
hemoperitoneum.
the RBCs?
So one
yeah,
is
if there is a
the
frank hemoperitoneum, or you can check if there
yeah,
are more
if there
than
is
1 lakh
a
RBCs.
frank hemoperitoneum, no doubt you can directly take. But if suppose there is no frank hemoperitoneum, then you analyze the fluid and look for the RBC. So how much RBC is significant in a DPL?
More than 1 lakh.
Yeah, more than 1 lakh per cubic millimeter. Okay, so if that amount of RBC is there, you can also take the patient to the theater. Or if without a negative DPL, if you suspect that still the patient is having persistent hemodynamic instability and abdomen is the source, you can also take the patient. So this is how the imaging in the blunt abdominal trauma, EFAST, DPL and CT abdominal pelvis. Now, this is something the modified procedure is now being practiced, something called as the diagnostic peritoneal aspirate. Okay. So what I have discussed. Now the patient was shifted to the OT. Now, upon exploratory laparotomy, operating surgeon found it was difficult in salvaging the spleen. Now, the surgeon can conserve the spleen in trauma up to the grade 4 injury also, grade 5 injury also. Similarly, with the liver injury also. Okay. Most of the time now the concept is from the in more invasive to the less invasive or conservative approach. He was shifted to the ICU with 2 drains in both the hypochondrium, and during the procedure, he has required almost many units of blood, FFP, platelets. So it's like a something called as the lot of transfusion has been given because of coagulopathy and ongoing bleeding. So if the patient already received so much unit of blood, RBC, FFP, platelet, cryo, what do you think?
Has DIC? DIC?
So this is something called as the massive blood
Massive
transfusion.
transfusion.
Massive blood transfusion. So you have to activate. So the massive blood transfusion is activated in 2 clinical scenarios. Either when the trauma patient comes to the ER, where you activate your lab because of the ongoing bleeding, or second, when the patients are being taken to the OT. That cases, if the patient has a ongoing bleeding after opening of the abdomen, that case you can activate your massive blood transfusion protocol. Okay, so how do you transfuse in such scenarios? Massive blood transfusion protocol. How do you transfuse?
1 to 1 to 1.
1:1:1. Yeah.
RPC. And the
So we can keep
warming, use warming. Yeah.
Yeah. Then
And they can use rotem or TIG for
very
guided.
good, very good. Very good. So what I wanted to listen from you is the TEG or ROTEM, and the massive transfusion set blood sets are these packs that comes in a packs actually. So you have to ask for the packs. So one pack means 1 RBC, 1 plate, 1:1, 1:1:1 ratio. RBC platelet to the plasma. This is called one pack. So by this you have to ask for multiple packs and guide your transfusion as per your TEG and ROTEM. So what is TEG and what is ROTEM?
viscoelastic point of care testing for platelet function.
Yeah, what is anybody has seen the ROTEM?
No.
So what is the difference between ROTEM and the TEG?
In TEG, the cup will rotate, or in ROTEM, the pin will rotate.
Cup will rotate.
In
A pin is there. The pin rotates basically with the shear force along with the cup of blood. Okay. And what is ROTEM? How does it, what is the principle of ROTEM? See, these are the very point of care testing, which is more and more gaining popularity nowadays. So go and read ROTEM more. Okay, now because these are going to be the future. So ROTEM, how does the working principle? What is the working principle in ROTEM?
Pin rotate.
Same viscoelastic
No, pin rotating the
cup
take.
rotates. Where the cup rotates.
See, pin rotates in the cup is a take. In ROTEM, what happens? What is the principle? It basically
the cup rotates.
That is basically cup rotates it generates a torque actually. So it works on the principle of torque, producing a torque. Whereas the take basically it's works on the principle of shear force. Okay. And these are all point of care viscoelastic. So ROTEM takes into account more and more the viscoelastic properties of the blood. And what are the different components of the ROTEM?
Intem,
So,
extem, then
intem, extem,
heptem, haptem, aptem,
and one more?
Fiftem.
Fiftem. So which is the more commonly used, more common like test, more common component?
So intem is for intrinsic pathway, extem is for extrinsic pathway. So for trauma, mostly it will be extem.
Yes. But most commonly, sometimes in other coagulation disorder, the intem is more commonly used. Haptem is for?
Heparin.
For heparin.
Haptem is to know the effect of heparin. It contains
Heparin.
heparinase, so it can remove the heparin and see if the intem is corrected.
Okay. And faptem is for?
For fibrinolysis, hyperfibrinolysis.
Hyperfibrinogenesis.
To remove the effect of platelet and only monitor the fibrin.
Right. That is it's called faptem. So the other aspect is the take. So take also I want you to know detail about what are the different thromboelastogram and its picture and how to interpret it. What are the different parameters? So can somebody tells me what are the different parameters in take? So something called as the arc time, the K angle, the alpha angle, the MA, the lyse time, LY30, LY60. What are all those things? So what is our time? What is our time?
Range which depicts the coagulation factors.
Yes. So basically it is the time of latency from the start of test to initial fibrin formation. So these are basically both the test measure the clot kinetics as well as the clot strength. So there are something called measurement for the clot kinetics. So R time basically measure the clot kinetics. The other test measure the clot strength. So R and K measure the clot kinetics. Alpha angle, K angle, and MA measure the clot strength. Okay. So R value, if it is prolonged, particularly it's suggestive of what defect? Clotting factors. If the K time is prolonged, K time is platelet doesn't come in K.
Fibrinogen.
Fibrinogen. So basically K means the initial time of clots to the formation of clot up to 20 millimeter. Okay, this is what the K actually. And alpha angle basically measures the slope. It is basically the clot kinetics and strength. So basically it measures the speed at which the fibrin builds up and cross-linking takes place. That's suggestive of clot strength. So alpha angle is more or less assess the clot strength. Okay, and also simultaneously the rate of clot formation. So if the alpha angle is less, particularly it suggests that the clot is formed very, very slowly and the strength is also not that good. That is suggestive of hypocoagulation. Okay. Then something called as the maximum amplitude or MA. So MA means it is also one of the measure of clot strength. If MA is good, that means your adequate amount of clotting factors plus platelet. Here the role of platelet comes. Platelet plus clotting factors are there. So if your MA is less, you have to replace both platelets and clotting factors. So the most important thing before you assess both these tests, always do a fibrinogen level actually. Okay, because serum fibrinogen level is not represented by your particularly TAG or ROTEM. Though they represent the clotting factors, platelet, and other things, the fibrinogen, your quality, but the quantity they do not reflect. So you should aim a fibrinogen level of around 100 to 150. If it is not there, first you have to replace with cryo, then you have to go for your TEG and Rotem. And MA60, your LY30 and LY60 is basically defined as the clot lysis. So if there is a hyper clot lysis, particularly, hyperfibrinolysis, then you have to give antifibrinolytic drugs. So this is what, and these are the different, you can say the TEG, they may give you in the spotters also. So now first one is the hypercoagulable test. Okay. So here you find that the MA is very much wide, the alpha angle is very much wide. Okay. So this is maybe a hypercoagulable test, hypercoagulable TEG. The in two, you can see the R time is prolonged. So here there is a defect in the fibrinogen. So you have to replace with fibrinogen. Yeah. 3 is something, you can say it is something R time is little prolonged. It may be normal or slightly deranged coagulopathy. You may have to observe. You may not replace all the time. You have to observe and repeat the TEG after 2 hours. Okay. And the fourth one is the hyperfibrinolysis, where you have to give tranexamic acid or apoptonin to, you can say that, to stabilize the clot actually. So the aprotinin is basically one of the coagulant. It was used previously in cardiac surgery. The Rotem more or less your measure your aprotinin. It can tells you whether the aprotinins are required or not actually. Previously it was used in cardiac surgery. So that was being the Rotem can only tells you, not the TEG actually. Okay, so here you can give the tranexamic acid. So, and the conventional test, like you have to know about everything, the APTT, the PT, the INR, in what conditions the APTT get prolonged, what condition the PT get prolonged, what condition the INR get prolonged. So one measures the intrinsic pathway, one measures the extrinsic pathway, one measures the common pathway. So liver failure, vitamin K antagonist, then something called as your anticoagulation. So what are the tests you measure? Heparin therapy, snake bite, DIC. So APTT, PT, both prolong, only APTT prolong, only PT prolong, only INR prolong. Go and read. There are multiple causes. These are, you have to tell them rapidly, and there is very less time for discussion about all these things. Okay, but just go and read about the conventional test. Now also you have to read about the something called as the anticoagulations and something called as the factor 7. There are very few limited evidence of factor 7 in a trauma patient, bleeding trauma patient. Activated factor 7, I mean to say, and prothrombin complex concentrate. Now, the recent European guidelines have suggested that if your factor 7 is not available, you can go for prothrombin complex concentrate if you suspect there is a trauma-induced coagulopathy. Okay. The dose you find out as per the INR report. If it is around 2.5, you can use 25 units per kg. If it is 5, INR is 5, you can use 50 units per kg. But activated prothrombin complex concentrates are available. Okay. It takes into account 4 factors which are activated. Also activated factor 3 are also available. PCC, this is called 3-factor PCC. This is called 4-factor PCC. And the third one is also you have to go for the fibrinogen concentrate. Read everything about the fibrinogen concentrate, because this is you can use in liver failure with DIC, with anticoagulation therapy, with trauma-induced coagulopathy. Instead of normal FFP, you can use this fibrinogen concentrate. What is the advantage and disadvantage? They may go into the detail because these are now the recent addition to your block also. So this is about the R time, K time, alpha angle, and lysis. Now this patient overnight remain hypotensive. The drains were hemorrhagic. Of course, he has gone into a DIC kind of picture. Night duty doctors report patient is restless, requiring increased dose of sedation, paralysis. Your ventilator alarms are indicating high peak pressure. He has decreased urine output. So, and the drains are more. And of course, patient is tachycardic in spite of sedation. Urine output is also less. So, patient is having abdominal distension, DIC, decreased output. So, probably he is going into something called as your, and if you see the platelet number also less, your 33,000 creatinine is, yeah. And this is your something called as abdominal compartments. Abdominal.
You tomorrow school is I thought you holidays for you. Swati will do. We'll go to buy shoes today.
Yeah, what do you do?
1.5 hours class. Today 5 hours class. I had to burn. It's become omelette. If you keep egg,
Abdominal compartment syndrome.
Yeah, abdominal compartment syndrome. So this is little bit away from the trauma, but you have to know about also abdominal compartment syndrome. Okay. Now this patient is going into oliguria, and you need to place an internal dialysis catheter because you have decided to dialyze this patient, particularly CRRT. And during the insertion of a catheter by your junior, you find the patient had suddenly desaturation and patient had blood pressure has dropped, and there is a high peak pressure and plateau pressure, and this is the X-ray. So X-ray clearly shows it is right-sided pneumothorax. So you have to immediately put an ICD on the fifth intercostal space, and you have to decompress it. So pneumothorax in a trauma is always a clinical diagnosis. Do not say that I will diagnose pneumothorax on ultrasound, X-ray, I will wait for the X-ray. It is a clinical diagnosis. If you suspect it, auscultate, see your ventilator parameters, put an ICD, you can do an ultrasound, or if you have ultrasound probe, just quickly do an ultrasound and see the different signs of pneumothorax, particularly your lung sliding and stratosphere sign and all, and just okay. So here there is a critical incidents debriefing. So can you remain mute so that I can just finish?
He has work. I don't.
Just mute your mics. So here one thing is like critical incidents debriefing. So there is a protocol for critical incidents debriefing. Okay. There are 7-step approach. Nobody had told me actually on that. This is a very European standard guidelines. Every critical incidents, how do you describe? Because the examiner tend to ask you regarding this. You think this may be a simple question, but a lot of times these protocols need to be followed. Just like your delirium screening checklist. CAM ISU your delirium checklist. Similarly, there is a critical incident stress debriefing protocol is there. So go and read from the any standard books. There are 7-step approach, and you have to just tell them as per the same thing. Just like a family meeting, your spike protocol and SOAP protocol. This is also a protocolized approach. Okay. Now this patient remains comatose. After few days, CT brain is diffuse cerebral edema. There is a loss of gray white matter differentiation, no pupillary corneal or cough reflex, no gag reflex. Of course, patient not triggering ventilator. So how do you proceed? The examiner wants you to proceed for the something called as the test for the
brain stem
reflexes. So you have to tell them absolutely in this way. So first exclude the reversible cause, exclude the confirm that the coma, there should be a cause of coma, confirm the coma. There should you confirm that there is a absent brainstem reflex, fixed pupils, absent dorsi, corneal reflex, cough reflex, and then you proceed for the apnea test. If apnea test is inconclusive, you may go for a confirmatory test. What are the different confirmatory tests? Transcranial Doppler, your SPECT, CT angiogram, 4-vessel CT angiogram, EEG showing isoelectric alternance, the silence, and of course they may ask you how to do a apnea test. So just before apnea test, you make sure that your recent electrolytes are normal. Patient should be not hypothermic. You should not give any sedation. Core body temperature is normal. Systolic blood pressure should be more than 100. And patient should have a normal CO2 or at least normal CO2 with normal sugar. Okay, patient should not be very much acidotic. And patient should baseline CO2 should be between 35 to 40. Then you describe them the procedures for the apnea test. So how to disconnect the ventilator, how to ventilate, at what rate the CO2 is going to increase per minute, when do you terminate the apnea test, when do you call it as a positive apnea test, what do you discuss with the family, and after the apnea test, what are your protocols, second apnea test, when do you suggest for organ donation, how to take out the organ, how to preserve the cadaver, all those things maybe come into picture, and then final your organ donations. So just because the interest of the time, I could not able to cover all those things, but those may be, everything will be asked in your exams and the MCQ. So this is a 6-step approach for your apnea. Okay. And this is what like the other things. So maintenance checklist for brain dead cadaver potential donor. So these are the different checklists you have to maintain. How to maintain the hemodynamics, rule of 100. Okay. Maintain the blood pressure more than 100, heart rate around 100, urine output around 100, temperature should be maintained, respiratory rate. These are the respiratory parameters, endocrine. You have to supplement with hormone replacement therapy, hormonal replacement therapy, particularly insulin, thyroid hormone, steroids, electrolytes. Okay. and other support like Foley's catheter, NG tube. Patient should be on DVT prophylaxis. Your infection control, documentation, coordination, all these things are very important. Any questions? Or we'll just go to the sputters. Your CBS.
Sir,
Sorry?
I have just one doubt. If
Uh-huh.
they ask particularly how do you go ahead with ICD insertion or pericardial
Uh-huh.
synthesis, like you said, do we have to
Uh,
start from I will ensure airway breathing circulation, keep all the
yes,
difficult airway card
yes.
ready, all those things, or directly
Yes,
just
yes,
till
yes, yes. Absolutely. Consent, you start from the consent itself.
oh,
No, so yeah, because they are very standardized hospitals. They do follow everything and they want you to know this thing. Okay. So that is the reason. So uh, these are very important. So whenever you tell them, just tell them because these are the European examiners. So the examiner always tends to see to it that you follow a methodical approach. So rather than telling them too much, whether your methods are important or not, that is more important. That is the most important thing for them. So because in Indian scenario, most of the times we don't follow. If sometimes we just in a hurry we don't follow the proper path, but there they always follow the proper protocols. So okay, anybody has any questions? Somebody was asking about the ROTEM.
ROTEM is more important than TIG in European on this
Sorry.
exam. ROTEM in exam is important than TIG in exam
Yeah. Yes.
or the same.
No, no, no. ROTEM is important because see, these are the now the standard of care actually. So ROTEM is, but if you see the ROTEM is mostly followed in European countries, whereas the TAKE mostly they follow in the American-based hospitals. So this is how usually now the practice is little on this area actually. So most of the European centers they follow ROTEM and American centers they follow TAKE. So most of the times the examiner tends to ask you regarding the ROTEM. So that is the reason. Okay. Okay. So very simple CT scan.
Diffuse
Very simple.
cerebral edema with hyperintense lesions in the cisterns, probably subarachnoid hemorrhage.
Yes. So the question is not to show the CT scan, but to ask you regarding what are your how to approach this patient, what are the bedside tests to do, and what are the definitive management. Because this is a subarachnoid hemorrhage is a very favorite topic of the examiner. You go and sorry, one thing I just forgot regarding to describe all the trials of the trauma, right? So go and see different trials, crash 2, crash 3. Now the proper trial, the what are the things like the different trials for the fluid resuscitation, crash 2 and crash 3. Of course, everybody needs to know regarding the tranexamic acid because it's an important trial which improves the mortality. So one is the pre-hospital. The crash 3 is now the pre-hospital administration of tranexamic in head injury patient within 3 hours. Okay. So these are sorry. So go and read about these trials in the trauma. Okay, there are only 5 or 6 trials, but you should know about all these trials. So like the balanced your damage control resuscitation, the proper trial is probably balance control resuscitation, where you don't have to infuse too much of your crystalloids. And they have seen that this reduces your hospital length of stay and the ICU length of stay. This is so one just I told you. Similarly, here also the subarachnoid hemorrhage, you have to know each and everything because there may be traumatic SH, the questions may be on traumatic SH and on aneurysmal SH. How to differentiate traumatic versus aneurysmal from the CT scan. So the traumatic SH particularly in the periphery. The aneurysmal SH in particularly in the systems. The hemorrhage particularly you find out in the systems. Okay. If there is an aneurysmal SH, go for it. DSA with CT angiogram, find out the aneurysm, then go for a coiling or clipping depending on the base of the aneurysm, whether it is small or large, and depending on the patient clinical condition. Then what are the your different trials like nimodipine trial? What are the other trials, the mass trial, the magnesium trial? Then what are the complications? And what is the delayed cerebral ischemia? How to prevent it? What is then what are you do during if you suspect vasospasm? What are the criteria for vasospasm? How do you monitor? They may ask you regarding the transcranial Doppler. Okay, different your velocities and ratios, Lindegard ratios and other things. So go and read. So these are little bit theoretical, but they may ask you in the spotters actually. Anything can be asked. Okay. So treatment measures, intubation, ventilation, then hypertonic saline, the measures to reduce the ICP. What are the Columbia's approach for step down your ICP management? 7 steps. That also same. Hyperosmotic therapy, ventilation, head in neutral position, refractory ICP, supra-refractory ICP. What do you do? All those things may comes in your trauma actually. This is a very simple, but everybody should know about the waveforms. Okay, this is external ventricular drain, but go and read about the waveforms P1, P2, and P3, and out of the 3 waves, where you find that there is an increased ICP. B. So when P2 is called which wave?
Compliance.
Yeah. So one is called percussion, one is called compliance. Okay. So when the P2 is more than P1, then it is the raised ICP.
ICP more than 20.
Correct. ICP more than
20.
Okay. There is also something called as the Lundberg waves. You have heard of Lundberg waves?
Yes.
If A waves are pathological, 5 to 20 minutes, sustained raised ICP.
So there are 3 types of
B
Lundberg
shows
waves.
respiratory variation.
So which Lundberg wave suggestive of vasospasm? Which Lundberg wave suggestive of increased ICP? And which Lundberg wave is normal?
C is normal.
C is normal.
A is just increase ICP.
With impending herniation. Up to 50 mm, it may suggestive of impending herniation. And B is?
DCI.
Cerebral vasospasm. Okay. Also read about the Brain Trauma Foundation. I think 2 of the candidates didn't able to answer the Brain Trauma Foundation guidelines for the ICP measurement. What is the gold standard, invasive and non-invasive? Now more and more focus on the non-invasive ICP measurement, particularly the your EEG based monitoring, optic nerve cell diameter measurement, transcranial Doppler. There may be now invasive, non-invasive sensors which can be directly put on your brain, and they can measure your ICP. Okay, video EEG. So go and read all those things. Those are the yeah. Okay, this is same thing what I am talking about. Optic nerve cell diameter. What is normal? What is abnormal?
Normal,
less than
more
5
than
is
5
normal, more than 5 is
millimeter. Yeah, less than is okay.
Yeah. And do you know from where you measure? What is the exact point?
3 centimeters below the 3 millimeters below the optic disc.
3 millimeter below the optic disc. Okay, so this is the point where you measure. But the most important point here is it has a very high subjective variability. Okay. That is the reason your operator variability is very high. Then what are the different non-invasive ICP measurement? And
EEG, transcranial Doppler.
Transcranial Doppler, everybody should answer. Transcranial Doppler. This is also helpful in your brain dead conditions, also helpful for vasospasm, also helpful for measuring the ICP. If you have not seen transcranial Doppler, just go and see one video or any literature, find out from the literature how do they do and how do they interpret, see the equipments of transcranial Doppler and how to do it. Okay, we just keep this because this is a particularly something already discussed, not in trauma. This is one thing about the spinal cord injury, SCI. Okay, so what is the what do you think you see here?
C7 vertebral.
So I have put just a very simple, very simple complete transaction of the cord. Very simple plate. But the thing is that they may be like spinal cord injury itself is a big topic. I have not covered here in trauma the spinal cord injury. So they may be asked what is the difference between the spinal shock versus your something called as the neurogenic shock. Then something you may be asked regarding what are the different guidelines of spinal cord injury. What is Skyora? What is Skyora?
Spinal cord association injury.
Spinal cord injury without a radiological abnormality.
Yes, spinal cord injury without a radiological. Where in which subset of patient normally you find Skyora? Particularly, it is seen in
Children.
pediatric population, geriatric and particularly pediatric, where the spine is very flexible. You may not find a radiological problem, but the patient may experience some kind of paresthesia or paraplegia or something. Then spinal cord versus neurogenic shock. So normally most of the times, okay, so that you have to clearly know the clinical difference between spinal shock versus neurogenic shock. Okay, spinal shock is absolutely areflexia, hypotension, bradycardia, and this mostly happens because of the spinal cord injury. Okay, and neurogenic shock is
Distributed
only
shock.
only hypotension. Okay, only hypotension without any kind of your spinal cord signs, abnormality in the spinal cord signs. That is called the neurogenic shock. Sometimes it may happen because of the head injury also. How will you intubate this patient? I have not talked about the intubation in the trauma. This is a very important area. That is something called as the ventilation and drug assisted intubation. Normally now the terminology from rapid sequence intubation has changed to drug assisted intubation. So here you don't have to extend, hyperextend. You can do something called as, you don't have to do a triple maneuver, but you have to only do
Inline stabilization.
manual inline stabilization. Okay, manual inline stabilization with drug assisted intubation. Okay, and no head tilt and chin lift. Okay, and head in the neutral position. So what is the indication for if the patient has a cervical collar? During this, you can remove the cervical collar and one person needs to stabilize the cervical spine. This is the most important thing. You cannot intubate the patient with cervical collar. And second thing, you have to go for the something called as video laryngoscope. Whenever feasible, you have to go for the video laryngoscope. If you anticipate difficult intubation, go for early tracheostomy or cricothyroidotomy. Okay. So these are the intubation protocol in the trauma. This also you skip. This is not related to trauma actually. Okay. Now this. So last patient we have we have talked about the intra-abdominal hypertension. So this is basically to monitor the intra-abdominal pressure. Okay. So this is a Foley's catheter which is connected to a transducer and then it measures the bladder pressure. So intravesical pressures are the indirect measurement for the abdominal pressure. So this is the measurement for the what are the normal intra-abdominal hypertension and when do you say it is abdominal compartment syndrome?
If more than 20 will be intra-abdominal. If more than 12 will be intra-abdominal hypertension. If more than 20 will be abdominal compartment syndrome.
Along with
organ failure.
Organ failure.
Organ failure. Without organ failure, you can't. What level will transduce the equipments?
Iliac crest.
Iliac crest. This invariably these equipments nobody able to identify. So please go. First A is what is A?
Rapid infuser.
Rapid infuser set. Rapid infuser set in trauma. Okay. And B is
Cell-saver device.
Cell-saver device.
Cell-saver device.
Cell-saving device.
Cell-saver device. Okay. So these are both are very important things for the trauma patient. So rapid infuser set is where the patient is in hemorrhagic shock. You want to give fluids and blood rapidly. Then.
To 5 liters in
Yeah, and cell-saver is for to conserve your blood and blood products
salvage
during the surgery. After the surgery, you put this device in the OT and bring the patient to the ICU. This machine will continuously run in the ICU and it will collect the blood, whatever is being in the drains, and it will again auto transfuse to the patient. This is called the cell-saver. So it is not IVP. Somebody told CRRT machine, somebody told IVP. So it's not IVP or CRRT. It is a cell-saver. Okay, this also nobody has identified.
Brain tissue oxygen device monitoring.
Brain tissue oxygen monitor. So this is called ICOX monitor. Whenever you suspect or whenever you monitor the brain tissue oxygenation, you can monitor this. These are the different electrodes. You can just put the electrodes in the brain and you can connect the the catheter in the brain, and then you can connect to the sensor and you can see the PbTO2. Okay, PbTO2 is nothing but the brain oxygen tissue monitoring. So whenever the PbTO2, you have to interpret it like with the normal saturation. Like for example, your blood saturation is less and PbTO2 is also less. So this is something as physiological. But if your peripheral saturation is normal, but your PbTO2 is going down, so you have to check the site of the probe, or if the site of the probe is okay, then you suspect ischemia in that particular area, which is not good. So in that case, you have to again see what is the cause. Then either you have to do a decompression craniotomy, or you have to go for the ICP reduction methods, or go for your oxygen increasing the oxygen supplementation, or go for the your something called as the different ventilator strategy, or blood transfusion to improve the oxygenation and oxygen carrying capacity, all those things, So this is how you have to tell the examiner that I have to interpret the results. So absolute one value doesn't carry any meaning. So you have to see for the trend and you have to correlate with the peripheral oxygen saturation. Okay, there are few other equipments which may be asked. One is something called as the RIBOA. I think everybody of you are familiar with the RIBOA. What is RIBOA? Retrograde balloon occlusion of the aorta. So whenever the patient comes to you with an hemorrhagic shock and you find that there is no way like you can control the hemorrhage, then you can put this balloon in the aorta actually through the femoral puncture, and you just like create a tamponade effect to the aorta so that the circulation will be like your damage to, or your blood loss will be less by the time you
Could I see the picture again, please?
sorry
The image. Could I see the image again of this device?
yes. So you can go and find out from the book how does the RIBOA look like. Now, most of the emergency departments are now using RIBOA in a trauma patient, particularly polytrauma with severe vascular injury with shock, or cardiac tamponade with shock. They just put a RIBOA, then go for a definitive cardiocentesis and stabilize, and then followed by removal of the RIBOA. So these are the few recent advances actually. So I think.
So this is.
Sorry. Yeah. Tell me.
Right.
So this in general, we'll say in an exam, if this came in this equipment, we'll say we didn't remember a specific name. We can say this equipment.
You see, European centers, they're using it actually. I only searched the literature and I found out in the textbooks, which is now particularly written by the European authors. So that is the reason you should know. You should see how does it look like and what is its function and what are the things. So this is one of the part of your damage control surgery also, in fact, to reduce the blood loss from the patient in a trauma patient, particularly where you suspect there is a vascular injury. Okay. Any further questions, or just we can wind up? So was it helpful to you?
Yes, sir.
Okay. And thank you. Anything
Yes,
you would
sir.
like to?
Thank you.
Yeah.
Thank
Thank
you.
you too much.
Yes, sir.
Yeah. Any if you had any questions, or after that also you can take my email ID or my number from Fatima, and you can also give me a mail, send me a mail. We'll chat on the mail, no problem. Okay. But because trauma is a very vast topic, I have not covered pediatric trauma, geriatric trauma. Okay, a lot of things has not been covered. Spinal cord injury, those things have not been covered. Guidelines, trials have not covered actually. A lot of things need to be covered. So those things you again read, and then it will be helpful to you. Otherwise, it's not possible to cover in a single class actually. Okay, that is the reason.
Thank you so much, sir. All the aspirant will get the PPTs via email. So all the best for your examination. Tomorrow too, we have the debriefing session. I'll be sharing the schedule soon. Thank you, everyone. Thank you, sir.
Thank you very much. Thank you to all. Yeah. Thanks. All the best for your exam. Yeah.